Hey GP learners, online consultations has rapidly become part of primary care. Many clinicians out there are learning how to deal with this new method of discussion, communication and engagement with patients. And it can seem a little bit intimidating, a little bit scary and also a little bit exciting. I'd love to tell you that I know exactly the depth of this kind of situation. I don't. I know the theory, I know the practice to a degree, but I thought it's much better that you hear from someone that has been doing this mechanism of consulting with patients for several years. And for that reason, we've got our guest coming on to join us to explain the whole process. This is a clinician that's been working with online consultations for several years, and as a result of it has created various systems including eConsult, eHub and eTriage, and holds various other roles that we're going to discuss. The key thing about this episode is you're going to get amazing tips on how to use online consultation systems within your practice to make it work safely, effectively, and more importantly, save you time in your practice. Make sure you stick towards the end. We've got some really interesting stories for you that you may even find a little bit controversial. If you do find this useful, make sure you click the like button, definitely subscribe, sit back, relax, and let's learn about online consultations in primary care. Let's tech enhance your primary care and learning. Hey GP learners, in this episode I'm joined by a GP who works down in London, is part of one of the largest GP groups in London and has pioneered loads of work in terms of online consultations, including systems like eHub, eTriage and eConsult. Former Darcy Fellow and part of the NHS Digital Academy, Dr. Ross Dyer-Smith. How are we doing, Ross?
Very well, thanks. Pleasure to be here.
Thank you for joining us. And one of the things I wanted to cover in this episode, which I know loads of our EGP learners keep asking me about, is how do we do online consultations? And this may surprise a lot of my EGP learners, but it's one of the few areas of digital general practice I don't have a great deal of experience with because I don't use it traditionally in my regular practice. So rather than me making kind of educated guesses and filling in people, I thought it was much better I go to someone who knows and lives and breathes online consultations. And the first name that popped up was yourself. So tell us about online consultations.
Well, online consultations really have been a bit of a revolution in the past few years. I mean, I'd say over the past 4 years is where it's really sort of taken off. And I think some people early on didn't really understand what it is. I think there's a better understanding now. But essentially, an online consultation is when a patient interacts with a clinician online. And there are several methods you can do that. So I kind of break them down into two. So I call them asynchronous or synchronous consultation. So a synchronous consultation would be a video consultation. So essentially the patient and the clinician are communicating at the same time. And there's asynchronous, which is a patient essentially submitting information about their condition and a clinician picking that information up at a separate time. So it doesn't need an appointment. So it kind of bypasses some of the difficulties we have with managing sort of capacity and demand. And they both have their sort of place and strengths and weaknesses. And my major experiences with asynchronous consultations, but I do synchronous ones as well. And part of the skill of doing online consultations is recognizing when one supersedes or is better to do than the other.
Yeah. Okay. And I guess a lot of this has been driven home because we've obviously had COVID happen, first of all, which has just changed everything. But in addition, there's this whole concept of moving towards total triage within general practice, which obviously came into effect a couple of weeks ago. And as a result of that, many practices are now starting to look at using online consultations, potentially as that digital doorway into the practice in terms of how patients engage with us and things. I find it interesting that I think a lot of people probably have been doing elements of the asynchronous consultations for quite a while. You know, the message through reception, in effect, is an asynchronous consultation to some degree, although it doesn't have the direct interface with patients. And I think that's one of the things that online consultations allow that process to do, hopefully freeing up your front of house. But I guess, where did your journey start with it, first of all? That'd be quite useful to know.
So many years ago, it seems now, one of my GP partners was basically sat in a surgery and saw 4 cases of hay fever on the bounce and said exactly the same thing to all of them, and just thought everyone's had to come down to the practice, take time off work, and I've told them exactly the same thing. There must be a better way.
Mm-hmm.
And so they basically got a team of doctors together and said, how could we do this better? They looked at other asynchronous routes. So they looked, email was obviously the one that kind of popped into people's heads straight away. And text messaging as well was another one.
Mm-hmm.
One of the difficulties with it, as I'm sure you know, is when you do have a kind of open form of communication, the conversation never stops.
Yep.
And we realized actually you can't close what we call the loop. So you need to be able to kind of close an episode. And the problem was with sort of text or sort of chat or email is that there's that loop just is continuous. So we needed a way to try and create an asynchronous loop that could actually be closed off and completed, so that episode care could be completed. And that's how the form of online consultation that we use, that we created, eConsult, came about. I was one of the guinea pigs, so I was one of the GPs that first started to do it. Mm-hmm. And I can honestly say I was pretty terrified actually when I started. I often tell the story of when I was a GP registrar, when I first did a telephone consultation. I'd actually been a doctor for 10 years in surgery before I became a GP, but I'd never consulted with a patient over the telephone.
Okay.
I'd opened people's abdomens up and removed their bowels and made major decisions around clinical care independently with my role in surgery. And suddenly, somebody who was quite confident in making high-risk clinical decisions was terrified of a telephone call with a patient. And I can still remember the case. It was basically a mum with a child with a fever. And all I could think of is, this could be meningitis. What if I get this wrong? How can I possibly know over the telephone? And of course, there was nothing wrong with the child at all. They had a minor illness, basically. But that's what went through my head. So I describe to everybody who does online consultations, that is the way that you're going to feel when you start. It's not going to feel safe. It's going to feel very unfamiliar. And the instant reaction when that happens is for you to revert to what you know, and what you know is face-to-face. So my journey is the same as what everybody else's journey is going to be when they take on online consultations. You'll start off very nervous. You'll get more experience as you go along, and then you'll start to realize that it is a safe way to consult with patients. And as you get more experience, which is obviously the best way to train, you get better at it, and you feel safer with it. You get quicker at it. And there are ways to sort of accelerate that process. And, part of one of those ways is to do some training, listen to these kind of videos, of course, as well, where you can get some really good top tips. And that helps people move quicker along that journey and get to a stage where they feel comfortable. But I'd say one of the key things is, with any online consultation tool, is being familiar with what it does and how it works. And there's two reasons for that. One is it gives you assurance about the governance so that you know it's safe. And it also improves your empathy with the patient to actually understand the journey that they've gone through to get to you. So with asynchronous consultations, for example, a patient might take 2 hours crafting their response to you, their history. And for you to then perhaps respond with one line might not be satisfactory to that patient. So you have to kind of put yourselves in their shoes. So pretty much everyone I've trained, the first thing I do is I go, right, we're going to go through it like you're the patient. So let's do it, so that they know what's involved. And then I also show them how the kind of safety mechanisms work. So particularly with eConsult, it has a red flagging system. So basically, if someone puts in symptoms that are not really appropriate for a primary care interaction, it will tell the patient that actually this isn't suitable. There's something much more serious going on here. This is here's a more appropriate route that you need to go. And trusting that flagging system means that you know what's coming through is not majorly serious medical conditions. So that's the first thing. So I think some people, when they do online consultations, just think it's unvetted access and anything could come through, and there might be a heart attack sat in there somewhere that I don't know about, and how can I possibly know? And actually, if you go and look at the system and how it works, you can assure yourself that that's not going to happen. and the governance process, particularly with eConsult, it has 26 team members, ranging from ED and trauma consultants to GPs, to pharmacists, to dentists, a whole team of people, a couple of patients as well, 17-year-old and 81-year-old. A big team looks at this content before it goes anywhere. And actually that process means that actually the safety aspects, which GPs are often quite concerned about, is really, really robust. And the same goes for the kind of significant event reporting. So if something happens, rather than it coming back and going to just a GP and being very siloed, so any kind of SCR will often just be looked at by GPs in primary care, and in secondary care by secondary care doctors. With online consultations and eConsult, for instance, they get both views. So you get a non-siloed team looking at significant events to get a more sort of nuanced response to an incident, to try and improve anything that comes through that might have caused an issue. I'd have to say we've had virtually none. I mean, we've probably had 3 or 4, and I think overall the whole eConsult estate probably only had 30 or 40. So it is a safe system, and I think that's just such an important thing for GPs when they're starting to do this, is to actually have some degree of faith in the system that they're utilising. Really important.
Okay, and you mentioned obviously a lot of the governance and security that comes with your own system. I guess it's important to mention that there are other systems around. I think on the DPS there's currently about 30 plus different systems available. Yep. How could someone kind of look into the other systems? How could they evaluate that? Because I guess that's, like you say, that's the thing that many GPs and many practices want to make sure is whatever they're using is safe. That's a priority, clearly. Can you give them any tips on how to assess that?
Well, firstly, I mean, you need to look at what you're trying to achieve and have some kind of idea of what kind of service you're trying to actually run. Because then you can look at what their specifications are and what they can actually provide. Does it meet the requirements that you need? The other thing is to look at the safety case reports, which gives you an idea of the kind of governance processes that go on behind it. And also there's various bodies now which are sort of setting standards, which obviously when we first started, because it was so new, there wasn't really any kind of, I suppose, regulation for these kinds of things. And that's tightening up now. So NICE has a process whereby it evaluates things. Obviously the DPS as well itself does have a process to actually get on there. So there's a lot more assurance going on than there was in the early days, where it was a bit like the Wild West. But now it's much more robust, and you've got the ability to go and look at those evaluations, and obviously more evidence is coming out as well now that people can look at and assure themselves. And there's case studies, there's some national guidance from NHS England people can look at, and obviously speaking to people who've got experience with utilising it. That's also a very good way to assure yourself as to how it works and how safe it is.
Okay. So could you talk us through the journey that a patient would experience with, for example, using a online consultation system?
So, I mean, obviously I can go through a few that I know, and the one I'm most familiar with, of course, eConsult. So a patient basically would go onto a practice website. That practice website would have a banner on there that essentially points them towards online consultations. And you can kind of configure that to be as, how would I put it, aggressive as you like. You can make it pop up first thing, or you can put it somewhere where it's visible and maybe slightly less intrusive. But actually what we've found is where you put it on your website is absolutely critical. So one of the big mistakes that practices often make is sticking a tiny box in the corner, which isn't visible at all. And you're not going to get the footfall if you do that. So you have to quite heavily promote it. So it's there for patients right in front of them. They can search by condition, they can search by body location, they can search by symptom. And if they don't know that, what they're kind of after, there's a sort of generic route in from a clinical perspective. And there's also an administrative function as well. So if they've just got an admin query, like, I need a letter to fly somewhere, or a copy of my medications, that kind of stuff, there's a particular portal for or route in for the administrative online consultations, which are a bit shorter, obviously, because they tend to be a bit more sort of directly transactional in that regard.
Mm-hmm.
And if they go through one of these particular routes, so say for instance they're consulting about a headache, and they headache online consultation will ask them sort of questions around a headache history, essentially, and it will ask more questions than a GP ever would in a surgery, purely
Mm-hmm.
because it's got the time to do it. And that's
Okay.
one of the great things about asynchronous consultations is you can ask a lot more than what you normally would do in a face-to-face interaction or a video interaction, because
Mm-hmm.
it's the patient's time. They can take as long as they like, but you can compress that time out the other end, so you get a lot of rich data. So it will ask lots of questions. How long has your headache gone on for? It will ask kind of red flag symptoms. It also will pull out the really important part, which is ideas, concerns, and expectations. That's pretty much the first thing they actually get asked,
Mm-hmm.
which is great from the clinician's perspective, because actually, almost instantly when you get it out the other side, you know exactly what that patient's after. I sometimes describe face-to-face consultations as a bit of a dance,
Mm-hmm.
where you're trying to work out which direction the other person's going in, and it can take a little bit of a while to work out what that is. What I've found with online interactions is people are straight to the point very quickly.
Mm-hmm.
That's particularly useful for things like mental health, sexual health as well,
Mm-hmm.
which was quite a surprise.
Mm-hmm.
I thought people might be a bit more cautious, but no, they just go straight for what they're worried about and what they hope to get out of it.
Mm-hmm.
So those questions, basically, when they're all done, collects a little bit of demographics. If the patient hasn't already gone through via NHS login, so actually patients can use NHS login to take their demographics through.
Okay.
And then out the other side, essentially, you get, once they press submit, it essentially gives them the option to have a copy of it.
Mm-hmm.
It can also signpost them to sort of self-help stuff as well. And a report essentially comes through to the practice, essentially with that data, that history collected for the GP to see out the other end.
So I guess with that then, when patients gone through that process, obviously that goes through to the practice. How does that come through to the clinician? What kind of experience do they have once patients submitted their information?
So it depends on what system you've got and what methods you choose. So when we started, it was a PDF just emailed to NHS Mail box of the practice, and that's now moved on to interoperability now. So essentially, we've got the ability to push it straight through into clinical systems now. So it goes through into workflow. So GPs can process it directly from there. And also other sort of third-party providers that might do document management. So DocMan's a good example. You can push through into that as well. So essentially, those eConsults come delivered in. They've got a header that tells you roughly what the problem is. So if patients use the sort of headache template or a back pain template, and it comes through with their kind of demographics as well, and also any kind of a number of sort of red flags or amber flags that might be in that eConsult are also in that subject line as well.
Okay. So I guess I know some of the concerns speaking to colleagues about how this may work. I mean, there's a couple that come to mind. Number one is that it creates another kind of lane in the motorway mechanism, because obviously demand is a massive challenge for many practices right now. And clearly that the worry is that it's another route to get to me. And I'm already struggling with the various ones. I mean, I remember mapping out the various different ways that somebody can contact me as a GP, one per line. And I was already on 2 double sides of A4, and I just gave up after that point. So, there's lots of ways that we are contacted, and I guess people are just worried that it's another method, isn't it?
I mean, it's a great question, and one that I get asked all the time. And I think what I say to people is, look, you have to see it as you've got to turn something off. So you don't open up another lane. What you do is you close one lane, then you open another lane. And you do it simultaneously. So that's the best way to use online consultations, because the advantage of online consultations, for instance, over telephone and even video actually, is you're getting the heads up before the patient is coming to you. So a telephone call, you might get a line from a receptionist that's booked it in, for instance, saying, headache. An online consultation, you'll get a bit more than that. So you can actually make a decision about where you need to slot that. But I totally get when GPs say, well, hold on a minute, we're already overwhelmed. How's this going to help? Well, it will help because you can manage what needs to be seen first, what doesn't. It will push some stuff away that shouldn't come to you. You can immediately hive off all those admin queries that come through on telephone triage. I'm sure, everybody who's watching this has had a day where they've done, 5 calls back to back and they're all about administrative stuff, not about clinical stuff. So it's really important to map out how you're going to structure how the practice is going to function with online consultations. So I'm a big fan of process mapping. This is something that I did quite a lot of as part of the NHS Digital Academy. That they were really good at getting us to see how important it is to map out a process, but making sure that when you've mapped it out, that you get a wider group of people involved in it as possible. So reception, nurses, to work out how that flow is going to work, and then make sure you go back to it, because actually you're going to learn from when you implement something like this, what things work really well in your practice and what doesn't. Because every practice, as we know, has a unique demographic. They behave differently. We almost train our patients at practices about how to interact with us. So you have to make sure you bring your patients with you. You will get a 3-month period of uproar. Doesn't matter what you do. If you switch from a face-to-face to a telephone triage model, that will happen. If you change from a telephone triage to an online consultation model, that will happen too. But as long as you plan it and you think to yourself, okay, we're going to put this capacity here. What are we going to switch off so that actually we're operating within the capacity that we have in the practice? That's really, really important. And if you do that, you won't go wrong. You won't go wrong if you do that.
Yeah, and I think it opens up opportunities as well, doesn't it? So potentially aspects like remote working, definitely, it can enable that to be more effective. And, even engagement to a degree with patients. I know so our practice does quite a lot of telephone triage, and we often get the whole, well, I don't want to tell the reception my health issue, because there's this perception that it's not confidential, even though clearly it is. And obviously significant amounts of training go into that. But sometimes telling a computer feels a little less of an issue to some people, and therefore potentially easier. And that's where you get that richer data potentially in terms of what you're describing.
Absolutely.
I guess one thing I wanted to question, so obviously for the past few years, many practices have had, triage-based information that comes from other providers like 111 and, those kind of systems. How would you describe, an online consultation being different to that format of data that we get?
So the key thing is actually your ability to see what's important. And I think all of us have looked at some of the 111 reports and have been slightly surprised at how little they've changed over the years. And actually your ability to see what's important in those reports is really difficult. And one of the things that the team focused on was to actually draw the eye. So actually the online consultations that I received, they've got red flags, amber flags, and a little what we call a free text icon. Essentially what it's saying is, look, this stuff you have to look at. And it will draw your eye to those things intentionally, because actually they're the most important things. People often say to me, look, Ross, how do you manage to do online consultations so fast? And the reason is I don't really read a large proportion of it. And again, that comes back to the point that I said earlier around trust. So I trust that the system is flagging all of that stuff correctly to me. So when I started, I read every single line. And this is things like, have you been abroad? No. Now, it's not actually a relevant sort of diagnostic potential question in a lot of cases. So and yes, okay, it's a small question, but reading all of those kind of negative findings that are not particularly relevant means that you're taking less time to do it. So you're focusing in on things that, a red flag on a pain score or a particular symptom that's important in that condition. The free text boxes you absolutely have to read. So if I was to give a tip to everybody watching now is, anything that's got free text, you have to read basically. And also it's, one of the richest things that gets you quickest to your management decision is actually that stuff. So that's how I, shorten my consultation time. And that's how it's presented in a much more structured way than what you might get from a 111 report.
Okay. And I guess with that free text kind of concept, obviously one of the challenges many clinicians are facing is that patients rarely attend with just one problem. There's often the list.
Yeah.
How does that kind of work with online consultations? Because clearly this requires the patient to offer the information, but I guess these systems may take a bit of time if they were to go through every single potential issue. And like you said, it's the patient's time, but some patients get bored.
Yeah, I mean, we've still get consultations where people will list three things, and you approach them the same way that you would do in surgery, which is, if you need more information on it, then you're going to have to call up that patient and get that information, or potentially see them face to face. But the key thing is that they're coming with three problems, whereas when they turn up face to face, it's dropped on you. Or you get the door handle consultation where, oh, by the way, doctor, and then they give you the fact that they've got rectal bleeding. You don't get a surprise. And I think that's one of the key things about it, that even though patients still do it, and I would have to say it's absolutely the minority. It's a lot less than what you would expect. And I think that's because of the way that it's structured, the way that it asks questions, because they're very focused on that it focuses those questions on that particular condition. It's very difficult for someone to start talking about the pain in their toe when they're being asked questions about a headache. So sometimes they will submit a couple. Sometimes they might just mention it in the free text, and occasionally you're going to have to pick up the phone and speak to them in those cases. So yeah, it doesn't go away, but it just is a better and more structured way of organising your team and your capacity to actually deal with it.
And with that kind of outcome look, so clearly you've got the information from the patient in terms of what they're presenting with. Many people probably feel quite comfortable from going from an online consultation to a face-to-face. As you said, that's a danger to some degree if that's what your only outcome is. Clearly there's the option of going from online to telephone or online to video consultation, potentially even, although I tend to recommend, it's normally better to go from telephone to video rather than doing it the other way around, because I think you get richer data. But how would you give tips to people that want to kind of close the consultation at the online pace? Because that's I think the part where many people would feel less comfortable with.
Absolutely. So again, comes back to that experience of myself doing a telephone consultation. Experience will show you. But if I was to give you some tips, the first thing is, if you have enough information to make a management decision. And when I say enough information, it's not just the online consultation that you're looking at. You've still got the whole GP medical record. In addition to that, certainly in London and lots of other places now, there's integrated hospital records as well, which has hugely improved our ability to practice safely. The time where, a patient has been to an outpatient appointment, you don't have the letter, and suddenly you're able to look into the hospital system and pick that up. So my top tip is make sure that you've got all the data available to make the decision first thing. If you think it's something that can be dealt with remotely, the quickest way to confirm that really is to think to yourself, is there any kind of examination that's absolutely critical in making this management decision? And to be even more specific, is it going to change what I'm going to do? That's really the key question. I often use the example of, you need to think a bit like a radiologist. So all of us as junior doctors doing surgery were sent to the radiology department with a request for a CT scan on an abdomen, and sort of clutching it in our hands and nervously asking the radiologist whether they would do it. And the radiologist would always come back with, how's it going to change your management? And actually that's the question that you should ask. So when I train doctors in online consultation, as soon as they give me an answer and say, I'll do this, I say, how's that going to change that decision? Is it going to change the outcome of what you're going to do? If you call them in, is your decision still going to be the same, even if you find a positive examination finding? And often the answer is no. And I go, well, why would you call them in for an examination then? So actually, you have to think slightly differently. And actually all of us have been trained that way. We were all trained as doctors to do history examination, investigation, etc. And actually you need to turn it a bit on its head. And you need to sort of unlearn what you've learned, really. if you do end up calling a patient, say for instance you think, well, I'm not too sure, I think I'll call them up, which is normally your kind of secondary response if you can't completely close it remotely with a message, is number one, don't recollect the history. I would say 100% of doctors that I sit next to who do their first telephone interaction with an online consultation, that opening line is, so tell me what the problem is. And the patient's spent maybe an hour telling you exactly what the problem is. So what you should be doing is formulating in your mind, what are the 2 questions, 3 questions that I need to ask to be able to make the right management decision? And then you open with, thanks for your online consultation. I'm sorry to hear you're not feeling very well and that you've got back pain. I've got 2 questions for you. Number one, has anything changed since you submitted that online consultation yesterday, for instance? And the answer is no. You might then go on to, a more clarifying question about the history to help you make a decision about whether you need to see that patient or not. Or it might be you're calling them because it's a complex sort of management that actually you need to explain in a lot more detail. There are other situations whereby a video call might add to that data even more richly. So it might be you want to eyeball somebody, or you just want to get a feel for how they are. It doesn't tend to be a huge number, actually. We probably only video call about maybe 1% of patients that come through via an online consultation. And we kind of see it a bit like a stethoscope, really. It's a good tool for the right patient. It works brilliantly well for the right patient. And those patients tend to be ones that either quite well, because often that just helps keep the rapport going, that you feel that there's you might want to see something movement-wise. So if you want to assess a joint or something like that. Rashes, I think some people think video works quite well for them. Currently at the moment, unless someone's got a really, really good camera, I think a static photo is much better, and online consultations do have that. So, but it still helps, maybe if you want to look at the actual body area that has it and the extensive nature of it, that can sometimes help. So making those decisions about, what tool is going to work best helps. But certainly the key thing really is it going to change my management? And even if it isn't, you can't make a final decision. If you can't close off that case, one of the things you can do is you can move that patient along their journey. So often you'll find people will go, well, I can't solve this problem. I don't know what the diagnosis is. I'm not really quite sure. I'll call them in. And actually what you should do is just think to yourself, well, actually, if I do see them, what are the decisions I'm likely to make? Whatever happens. And often that might be, I'm going to do some investigations. I'm going to do some bloods. I'm going to do an X-ray, I'm going to do an ECG. Well, actually, move the patient along their journey. So even though you might not make a diagnosis and bring it to its conclusion with that first interaction, what you can do is furnish yourself or whoever the clinician might be that follows them up next with all the information and data and investigations that they need to complete that decision, which means that actually the patient then doesn't turn up for a face-to-face, then get sent away for investigations, then come back again. You can do a huge proportion of that journey online that's more convenient for the patient. They only come in for the test, for instance, and then you can make the diagnosis. So that's one of our core principles in the eHub that I run is saying to everybody, look, if you can move the patient along their journey, that's what you should do if you can't make a conclusive management plan.
And I guess there are some really important aspects to think about. There are some patients where it potentially doesn't work as well for. I guess the ones that come to mind are patients with just literacy issues, and that can be either down to learning difficulties or other clinical health issues. And I guess the other one is the non-English speaking. Have you got any tips on, I guess, how those two cohorts can either be used a little bit more effectively with online consultations or just better ways to make it flow?
So, I mean, the first thing I'd say is the online consultation language is targeted at an average age of 7. So it's designed to try and be understandable as best as is possible. But clearly, as you quite rightly point out, there's a limitation if you're doing something that involves literacy. And that's why we say, look, it isn't for everybody, much like a telephone call isn't for everybody, and much
Mm-hmm.
like sometimes a face-to-face isn't for everybody. And there are going to be cohorts that are going to be find it much more difficult to do an online consultation, and you should plan that into any kind of process map that you have at your practice. What are we going to do for the patients that can't potentially use this route? Now, what I would say to you is that if that's the case and you think we've got a cohort particularly that's difficult here, is think about where you can free up some space by channel shifting that demand somewhere else. So yes, the bigger proportion of people doing online consultations is going to be the kind of sort of 25 to 50 age group. But if you can do more with less, you've then freed up some capacity to actually provide to those people who don't speak English, who might need a translator, for instance, who will always take more time. So you can actually free up some capacity for those patients, and also planning that route in for them. You know, how are you going to do that? Because those people who don't speak English still have the same challenges approaching a practice via telephone, for instance.
Mm-hmm.
So you have to accept that it can't serve everybody, but it can serve a massive proportion of your population. Some people will even get their relatives to help them out to do an online consultation, which is fine. But you still have to take that in a way with the same kind of caution that you would do if you had a relative translating in a room, which often happens when you see people face to face. Sometimes bits can be lost in translation. There's always an ambition, I think, for all the providers to get a sort of multi-language as well at some point, and I'm sure that will come. But yeah, planning a separate route in for those individuals is really important. But I would say that those groups are getting increasing accessibility as time goes on, as technology develops. So some of the interfaces now will read what's written on the screen, will record the spoken word. So all of those technologies can be utilized as well for some people if they have the confidence to do it.
Definitely. And I think with clearly COVID has shifted a lot of people to use digital methods more often. And like you say, the tech is also improving. So we're going to have speech to text, which will help for those people that struggle to type. Language translation services potentially are something that may improve even further. I know CQC hates us using things like Google Translate, but actually for certain languages, it's pretty good, to be honest. Yeah. If you look at it, they use European data, council data to ratify it. So it's as good as what they do for, the European MPs and that kind of thing. But I think it's definitely an area that needs some consideration, like you say, and thinking about that journey for the patient in terms of where they're going to end up, because as with all of our patients, you can never apply the same brush to every single one. That's part of the richness, and that's also part of the challenge that comes with doing general practice, really. So yeah. And I guess one thing I would really like to hear from yourself, clearly you've got amazing experience and years of experience of doing this. Can you give us, I guess, without obviously breaching confidentiality and all that, a case that made you think, yeah, this is where it just did what it should have done so amazingly? Does that make sense?
Absolutely. Do you know what? I'm so glad you asked me that question, because there has been episodes of care that I've just thought, this has gone so much better than it could possibly have gone if I'd done a face-to-face. And I'm going to tell you two that are quite controversial. And some of people watching will go, oh my goodness, you can't possibly do that. But this is what you experience when you're in a kind of disruptive space. You start to see things that you'd never saw before. So the first one was a lady who did an online consultation around a breast lump. As soon as I looked in the history, I'd seen that she'd had a breast lump previously that had been seen, that had been diagnosed as benign, and nothing had kind of come of it. But clearly in the online consultation, she said the same lump was there, it had got bigger. There was absolutely, and her age and all the rest of it, I knew what the decision was going to be. Now, most people's reaction would be, oh my goodness, that's a breast cancer, you need to see that. And my reaction was, that's not going to change what I'm going to do. She's clearly got a lump, it's been there before, someone's examined it, it's grown in size, it's in the same place, She's absolutely sure that it has. She's got other symptoms as well. She's got risk factors. Did the referral there and then.
Mm-hmm.
So essentially, this woman consulted at I think it was 8:30 in the morning. By 10:30, I'd done a 2-week wait referral, rang her up, given her an appointment, and she was seen 2 days later and was diagnosed and treated for breast cancer. Now, in the real world, what might have happened is she may have called up to get an appointment. If she'd pushed the urgency, she maybe have got past the reception team, but actually she may have waited 2 or 3 weeks. Then there would have been a potential, a couple of days waiting to get her appointment. So I accelerated her through that process way, way faster than could possibly have happened if I'd done it face to face. So for me, it was massively rewarding to be able to do that. And actually for the patient, she submitted something at 8:30 and I called her back an hour and a half later, 2 hours later.
Okay.
So, and she didn't have to leave her home.
If I may then, so actually the outcome doesn't surprise me. I think that's how it should work. I guess the part that raised a question in my head is often we have, for lack of a better term, bureaucracy that often says when you do the referral, have you examined the patient?
Yeah.
And that's sometimes the stumbling block. Similar, I guess, examples would be when you're trying to admit a patient to hospital. There's the whole, have you actually examined the patient that comes down from, whichever place is trying to navigate the patient, so we say, a bit more effectively, or block it, whichever way you want to look at it.
Yeah.
That's the part that I think I don't question, but I guess that's the part that makes it a bit harder for me to figure out how to work it.
I think right now that we are in a period of the development of medicine where everyone is suddenly starting to recognize this. And it's a real shame that a horrible disease has had to turn up and show us all this. But our secondary care colleagues are currently running outpatient clinics completely remotely and realizing that actually they can do an awful lot of what they do without actually seeing people. Yeah. And so I think you will find that resistance will start to ease. Now, clearly, you can't do it for every case. I think that particular case I illustrate, as I say, does tend to be a little bit controversial for exactly that reason. But when I wrote the referral, I gave the history in detail and even wrote the reason why I wasn't going to examine and I was doing a referral straight away. Which basically was, and I think I even put my phone number on there, said I'm quite happy to take a phone call direct to my mobile if you'd like to discuss, in the sense that, I would have quite happily defended my decision if a consultant had said, well, actually, I really think you should examine them. I would have argued my case, but, the referral was accepted, the patient was diagnosed, we had a great outcome. And I think that's going to change. And I'm not saying that every single breast lump, you can just send in. Absolutely not. There are cases where you do need to examine it. But in that particular case, the evidence was overwhelming that there was a hugely high risk of breast cancer. And absolutely, there was nothing that was going to change my mind that was happening. It was, in essence, it was actually a really easy case. In that regard, the ones that are difficult tend to be the ones where you're really umming and ahhing about what to do next. But that one was absolutely bond. But my initial decision was I was going to call her in. It was with my first kind of brain thing really was like, oh, I've got to see her. And then I was like, no, she just needs to go to 2-week wait. She needs to be seen. The second case is probably even more controversial, really, but did show the power of utilising all the information at your disposal. This was a lady who consulted about actually she wanted some more medication. So she was having sort of diarrheal symptoms, and she was asking for some codeine, which helped kind of slow it down. And that immediately made me think, well, I better have a good look at this first. And actually, I looked through the notes, and she'd been seen by several GPs previously who'd done all the right stuff. She'd been referred to gastroenterology, but there was a 32-week wait. She actually said that in her online consultation. So, can I have some stuff to help with my symptoms? She didn't have any red flag symptoms. She didn't have any PR bleeding or anything like that, or anything that was particularly worrying. But when I looked through the medical record and scrolled through, all the results had come back. And there was a raised fecal calprotectin. There was a raised CRP. I scrolled even further through the notes, and there was a section about how her family members had IBD. And it just, the more that I read, I was just like, well, this is absolutely barn door inflammatory bowel disease. Absolutely, there's nothing that's going to change my mind. I had one question though, which was, I just need to be absolutely sure that this woman doesn't have an acute abdomen. And so I rang her up and I thought, well, I'll give it a go and see, how we get on with this. So I had a chat with her. How are you feeling? She said, I'm fine. I'm, just having a lot of diarrhea. Have you got any abdominal pain? None at all. I said, get up, move around, no problems with that. No, absolutely not. But
star jump test.
Yeah, it was just actually, it was, if she'd said, a bit, then, inevitably I would have seen her. But she had nothing that would indicate that she had any kind of acute abdominal symptoms. And so again, same thing, fired up Choose and booked her into the IBD clinic. She had all the investigations done. And yeah, she was diagnosed with Crohn's disease, and I hadn't even seen her. So, when I tell that story, you can hear the kind of that goes on in the room,
right now I can hear EGP learners across the country going, "Oh my God, absolutely. How could you do that?"
Absolutely. But I think the thing is that you have to make a pragmatic decision about, do you have enough information? Because in reality, in medicine, especially in general practice, we operate in an area of grey all the time. You can never be 100% certain about anything, but you can be as certain as you possibly can be. And you need to be able to justify it. And actually, I do think to myself on those cases is that if I had to justify myself to a gastroenterologist about why I did that referral, again, the evidence was overwhelming of what this was going to be. And yes, there were other things in the differential, but they'd all been ruled out. Infection, all that kind of stuff had all been ruled out by the investigation. So I was lucky in essence, and so was the patient. They submitted it, just at the time when the investigations had already been done. They'd already been referred. All the history was there. I just put all the pieces together. So in essence, I didn't really take, most of the clinical difficult stuff had already been done, and actually it was just about making sure that referral got shimmied along. But when I tell the story, it sounds like I've made this super risky decision from afar. And imagine how happy the patient was, because they were seen the next week as opposed to 31 weeks having suffered symptoms for 6 months. So yeah, it was a fantastic outcome.
And I think it shows that when it comes to these kind of outcomes, it's using that clinical reasoning to understand the individual patient circumstances and what does the next step mean for that patient, not for the condition. And I think that's where a lot of people potentially get sidetracked with, it's the whole patient's got a symptom of a headache. Oh, well, it could be raised ICP. But actually, if the patient demographics, if the patient history and, all the information you have about that patient says it's a tension headache, chances are it's a tension headache.
Yeah. And we have to take those risks all the time in face-to-face care. I think it's just because we're used to doing it in face-to-face care, it doesn't feel unsafe. But when you're doing it online, it suddenly does feel unsafe because it's unfamiliar. But actually, you still have to do the same processes. And some of my teaching sometimes, I do a few videos and things like that, and occasionally people will, criticize maybe my management, but I'll say it's not the management that's important, it's the technique of getting the right information and weighing it up, because you may very well make a completely different decision to what I would do with a individual case, but that comes down to your individual experience as a doctor. Things that have gone right and have gone wrong in your life when you've been practicing medicine, and how much experience and familiarity you've got. So it's not saying this is the way you should manage back pain. It's, as you rightly say, it's about assessing the individual, using your own experience, but just taking a step to just think, can it be done a different way? Is there anything else I need to make this decision safely? How can I move the patient along their journey? The patients, think about the patient and what they've had to do. What's their expectation? Is it going to be a good experience for the patient with the plan that you've got? And it's something that you get better and better at the more and more of it that you do. And it is like any piece of learning. You reflect on it and you get better each time.
Thank you for that. I mean, that's a great way, I think, to summarise everything we've been talking about today. I guess you mentioned some of the stuff that you've created. If our EGP learners did want to have a look at some of the content you've done, or particularly learn more about things like, eConsult, eHub, that kind of stuff, where would you suggest they go to have a look at that information?
So most of the stuff's on the eConsult website. You can follow me on Twitter, of course, at Dyer-Smith. And I sort of publish bits and bobs on the kind of case reports and blog stuff of the eConsult website, and on Twitter as well. I'm also at the moment developing a kind of educational program, which I hope to release in the next month or so, which is a kind of more interactive kind of learning. Some of it's video, but some of it's actually sort of case-based. And we're also going to start to run a few webinars as well, which we're starting to find is quite a good way of teaching people. Because in essence, case-based discussion, like all medicine, is always the best way, is listening to your peers and how they might manage it. Gives you a much better idea of where you are when it comes to actually online consulting. So there's plenty of stuff out there that I've put out already that you can go and have a look at, but there's definitely more coming as well.
Awesome. And when that comes out, I guarantee that we'll be sharing that with our EGP learners as well.
Fantastic.
So I'd love to thank you for your time, Ross. It's been really appreciated. I know I've learned a lot, and I hope a lot of our EGP learners have learned tons as well in terms of how to, I guess, look at online consultations and also not fear it, and potentially look at how this can be an improved way, as well as a more streamlined way of managing, hopefully, primary care, particularly in our post-COVID world, because that's what we're all having to do right now. As always, EGP learners, if you've got any comments or questions, you're more than welcome to contact myself on whichever platform you prefer: Facebook, Instagram, LinkedIn, Twitter, whichever. I'm on all of those. If you are listening on the podcast, love it if you'd leave a review. Really appreciate it when you do that, especially on iTunes. And as always, if you're watching on YouTube, make sure you click the subscribe button, ring the bell to get all of our information and episodes first and foremost, and definitely leave a comment. I guarantee you a reply. And as always, EGP Learning is here to help save you and your patients time by taking hands in your primary care and learning. And catch you in the next episode.